Our next speaker is Dr. James Lin, who is a previous Lenke Fellow and currently a spine surgeon at Mount Sinai in New York. He flew, 15 hours to be here with us? So he's going to give us a talk on cervical laminoplasty, how to choose the most appropriate patients. So please, James.
All right, good afternoon. Great to be in Hawaii, and thank you for the invitation to be speaking here today. I'll be talking about how to choose the most appropriate patients for cervical laminoplasty. Here are my disclosures. So as we heard from the previous talks, laminoplasty is a great operation for cervical myelopathy. Multiple studies have shown that it is associated with quick recovery, low complication profile, low C5 palsy rate, low cost, and you don't really have to worry about the adjacent segment disease or pseudoarthrosis. This is a study out of our institution that shows that compared to a posterior laminectomy infusion has much lower narcotic usage even 6 months after surgery. And so in a patient like this, who's a good candidate for laminoplasty, you can take someone who has severe multi-level stenosis and fix their problem in a motion-sparing and relatively minimally invasive way and decompress the spinal canal. The key question, though, is who is a perfect candidate for laminoplasty? Here's another example of a patient that most of us would consider to be a good laminoplasty patient. This patient presented with pure myelopathy, no neck pain. They have multi-level disease. They have lordotic cervical spine. The T1 slope is less than 30 degrees. C27 SVA is less than 40. There's good extension potential on the extension view. No previous surgery, no spinal listhesis. And so this is an excellent laminoplasty patient. This is also someone that I would call a laminoplasty unicorn. Is you don't see this type of patient that often with everything being perfect. And so if we only operated on this type of patient, we wouldn't really be doing as much laminoplasty and be underutilizing the procedure. And so I think when we're thinking about laminoplasty, I think it's important because it's such a good operation, like we talked about, it's very important to broaden our search maybe and ask who is maybe a good candidate or who is an acceptable candidate for laminoplasty. And I know that if I had multi-level stenosis, I'd much rather have a laminoplasty than either a multi-level corpectomy or a posterior C2 to T2 fusion. And so when I think about laminoplasty, basically what I'm looking for mainly is from their clinical, complaints. If the chief complaint is myelopathy, the cervical spine is neutral to lordotic, I'm thinking about laminoplasty as one of my primary options. Then I will assess two things. I'm going to look at what's their neurologic risk, meaning what's the risk that if I do a laminoplasty, I'm not going to adequately decompress their cervical spine. For the spinal canal, we look at the K-line. Also look at whether or not we can adequately decompress any symptomatic cervical foraminal stenosis. Then we also want to look at the alignment risk, meaning what's the chance to do a laminoplasty and they're going to fall into kyphosis or lose lordosis. And the things we look at there are the T1 slope and the C27 SVA. And, there is a category patient that I generally don't think of doing a laminoplasty as someone who comes in with a chief complaint of neck pain. And particularly in the setting of having multi-level bilateral neuroforaminal stenosis that I don't think I can adequately decompress in a reasonable time frame. And so we'll start with K-line. This is a concept described by Fujiyoshi. Pretty straightforward. You draw a line down the cervical canal. If the anterior compressive pathology crosses the line, generally not a good idea to do a posterior-based procedure or particularly a laminoplasty, and you're thinking about either an anterior fusion or a posterior-based fusion procedure. And so this is a 66-year-old male who presented to me with only myelopathy, no neck pain. You can see on his x-rays that he has a slightly elevated C27 SVA. The T1 slope is also a little bit high, 37 degrees. And if you look at the MRI, the K-line is favorable. And so based on all these factors, I'm thinking laminoplasty. But when you look at the CT scan, you can see that the OPLL is so overgrown that it's touching the lamina. So I didn't feel like in this case, if I did a laminoplasty, I'd be able to adequately with continued motion, particularly keep the spinal canal free. So I ended up offering this gentleman a posterior cervical lamina fusion, and he ultimately did pretty well with resolution of his symptoms. Now you can see that he did drift forward, a little bit over time. And, I think if I had to do this again, I'd probably go down to T2 rather than just stop at T1, given his elevated C27 SVA. Now, when we talk about alignment risk, this is the things that we look at are the T1 slope and the C27 SVA. So this is a paper that looked at 51 patients with 2 years follow-up, and they broke down the patients into patients that had a high T1 slope, they defined as over 26 degrees, and they found that high T1 slope patients, 50% of them drifted into post-op kyphosis, compared to the low T1 slope patients, where only 4%. Now, it's important to keep in mind that 15% is not particularly high, so that's about the chance of a pseudoarthrosis with a 2-level ACDF. So the numbers are not terrible here. This is another interesting case related to this. So this is a 78-year-old retired oncologist, also with Parkinson's disease, presented with severe myelopathy, no neck pain. Again, myelopathy, lordotic spine, I'm thinking laminoplasty. He has severe multi-level stenosis. He has a little bit of a spondy, and he has a very elevated T1 slope. And so certainly he has a high risk of loss of lordosis, maybe even kyphosis. But I discussed with him that, given his age, given his Parkinson's disease, that he might be a better candidate for laminoplasty. And that's what he chose. And that's what I would have chosen for myself as well. And ultimately, so I did a C3-7, dome laminectomy, C4-6 laminoplasty. And, he did lose some lordosis, but he's still, overall lordotic. And this is a video of him 4 weeks after the surgery. Is that going to play here? Oh. I can get this to play. A 79-year-old male who's about 4 weeks after posterior cervical laminoplasty. And up and down. Great. How much pain do you have?
None.
Excellent. So I was overall very happy with the result of this, and he had a very quick recovery, fairly minimal neck pain, in the postoperative course, which is very different from a multi-level fusion. So what about neck pain? So this is a, fairly controversial topic. But in general, I don't see neck pain as a contraindication to laminoplasty unless it is really like the chief complaint. The main reason they're coming to you is my neck hurts a lot. And if they have severe foraminal stenosis, that I think is the cause of the neck pain. This is a meta-analysis that actually shows that neck pain can improve after laminoplasty. So in general, I would never promise that to the patient, but I don't treat neck pain in general as a contraindication. So this is a 63-year-old female who presented with myelopathy. She really had a mild central cord syndrome after a fall, and she also had severe neck pain. And I thought this was interesting because if you look at her scoliosis x-ray, she had a obvious thoracolumbar sagittal deformity, and as a result, a very high T1 slope. And the MRI shows multi-level cervical stenosis. And you can see on her cervical x-rays, she has an elevated C27 SVA and a T1 slope of 52, which is also very high. So, we all know she's a very poor candidate for laminoplasty, but I would argue that she's an even worse candidate for a C2 to T2 fusion because you're going to leave her in a, compensated position and have a high risk of, junctional issues. So basically I told her I could fix her stenosis with no fusion, but I couldn't fix her neck pain, or I could fuse her neck and she still might have neck pain, and she decided to have the laminoplasty. And so I'll show you what we did. She did, again, C3 laminectomy, C4-6 laminoplasty, and 18 months post-op, as expected, she lost a little bit of her lordosis, which we often see. She actually also auto-fused C2-3, but overall her neck pain actually got a lot better, and she did overall pretty well. So I was pretty happy with this, but I was worried about it early on whether or not she would go into kyphosis. What about kyphosis? So, a lot of the studies say you can accept up to 15 degrees of kyphosis and still do a laminoplasty. I personally try to stick to patients with neutral or lordotic spines. And this patient had very slight degree of kyphosis, but technically you can go up to 15 degrees. Obviously, if you have severe kyphosis, you need something like this, like a fusion. I think one area that maybe is a little bit underutilized is short segment laminoplasty. So this is a patient who's elderly patient in her 70s, came to me with just myelopathy, no neck pain, no radiculopathy. And even though it was only 2 levels, because she was myelopathy and neutral spine, I thought laminoplasty would be a good option, particularly because she's got collapsed discs, so I would feel like I'd have to jack them up. And she also has a very juicy 4-5 disc, and I would be worried about the potential for a long-term adjacent segment disease there. So, ultimately, I went with a 2-level laminoplasty for her, and she did very well as well over several years. And then so I'll end with this case. So this is a 66-year-old male with, again, myelopathy and no pain. You can see on the x-ray lordotic spine, so I'm already thinking laminoplasty. On the MRI shows 2-level disease. So I think in this situation, a 2-level anterior cervical fusion, certainly a very reasonable choice. But when you look at the subadjacent foramen, he's got foraminal stenosis there. He's got no pain currently, but I worry about long-term you fuse those two segments and you park it on top of foraminal stenosis, what's going to happen? So ultimately, I decided to go with a short segment. I ended up opening up everything, but he needed a short segment laminoplasty. And again, this was, I think, in my mind, a more durable operation for him. And so in summary, I think laminoplasty is such a great operation, quick recovery. And I think we can be a little bit less selective, particularly in North America where we're, heavily favored towards fusions. And, if someone's coming in with myelopathy and a neutral to lordotic spine, I think laminoplasty should be at least one of the top, contenders for the operative choice here. Thank you.
All right, great talk, James. And obviously, all the X-rays showed you did a great job and preserved all C2 and C7 ligamentous attachment, muscle attachment, and whatnot. All look perfect. But I think in my experience as well, I think we looked at our maybe over like 150, 200 laminoplasty patients. On average, even if you have the best technique, I don't know, Dr. Sun, Professor Sun, maybe comment on this as well. We tend to see about 3 to 5 degrees of loss of lordosis. Doesn't matter what you do. I think the reason is that essentially you're cutting the posterior tension band, even though you're preserving 2 and 7, you're still cutting 3, 4, 5, right? And those muscles atrophy a little bit, and they have nothing to attach to, or much shorter lever arm, because we shave off the spinous process. Yeah. So, for me, like I think I was more aggressive with laminoplasty, but initially, but with the high T1 slope, I do see, some of them fall forward quite a bit, especially younger patient with mobile neck, and then you end up needing to do like a long segment fusion later on. And I do think that literature from Asia is a little bit different than population we see here, in that the OPLL patients are much stiffer, especially with continuous type. So in Japan, they may be able to get away with 13 degrees kyphosis because, well, they have a spike up and down the neck and they don't move much anyway. Yeah. Whereas I feel like the multi-level spondylosis, this, congenital stenosis patient is kind of different. Yeah. I don't know, in New York, I mean, do you check for OPLL? Do you treat them like differently than the multi-level spondylotic patients?
Yeah, I think in general, unless the OPLL is really past the K line, I think I'll usually try a laminoplasty first, because I think that's what the laminoplasty procedure was initially designed for, was OPLL patients. But I do agree that, certainly as the T1 slope goes up and the C27 SVA goes up, the chance of developing post-op, kyphosis goes higher and higher. But, in general, I think depending on what your overall philosophy is, I would rather offer a smaller surgery that's motion sparing. And if I have to come back and fuse them later, then we can do that. If you have to come back for an anterior procedure later, I think that's also reasonable, rather than going straight to the C2 to T2, which I think it just takes away a lot of your motion, and they tend to be slightly with the loss of motion, maybe some low grade pain. Laminoplasty patients really have no pain afterwards. They feel pretty good.
Professor Sun, do you have any comments or tips and tricks?
I think the post-operative kyphotic after laminoplasty depends on so many factors. And all you have mentioned in your presentations. And also, I think the most important thing is the muscular exercise after the operation. So, but in China, not too many patients will follow the instruction to do the back muscle exercise. But that's very, very important. So, and we are trying to set up a program for the rehabilitation in community centers. So maybe the patient they can follow up and also use the internet. So we have online monitoring by the surgeons and the physicians and physiotherapists, but it's still hard. It still happens all the time. Because sometimes it's hard to understand. But most important things for the younger people, don't force it. Just leave it mobile. But for the elder people, we always try to force it. Otherwise, the muscle will go in an atrophy. And after this operation, and for elderly people, they don't like to move, to do something. So it just fuse it and it's okay. But just before the operation, talk to the patient himself and also their family. And after operation, your neck will become a little bit rigid. But that will help you to get upright, to look forward. Otherwise, you'll get the dropped head or something. So they can understand. So it depends. I think sometimes the surgical decision making is sometimes hard for the people maybe under 70s. So you have to see what the patient individually is to make a decision. But ask just for the muscle exercise is one of the most important things after the operation.
Yeah, I agree with that. And, I tell every patient after surgery, like 3 times a day, you turn your head all the way to the right and you push it another centimeter and hold it there. All the way to the left, push it a centimeter, and then you look all the way up and you push it up. And I just do that 3 times a day. And anecdotally, I feel like that helps with the range of motion and the neck extensors. But
and some Japanese surgeons and Korean surgeons and also Chinese surgeons have developed some new procedures with a laminoplasty with muscle preservation by unilateral or bilateral. And so for the premier study, and it works. Can maintain the cervical lordosis and maintain the range of motion. But once again, even you preserve all the muscles, some surgeons in Korean surgery do endoscopic laminoplasty, but without any muscle exercise, all your works will go fail. So muscle exercise, patient's education is most important.
James, I think we need to bring this up just because there's such controversy about that high T1 slope. And I really find that a difficult one, and I think I tend to side a little bit. You pointed out with the high T1 slope that is a risk factor for progressive kyphosis. At the same time, Bobby pointed out that that high T1 slope of fusing across there can also be a problem. And those are the patients who are sort of on their way to a C2 to pelvis fusion. And Alekos just wrote up a very unfortunately large series of those. So I think I tend to lean towards, even though there might be a progression towards kyphosis, to Bobby's position about maybe doing a laminoplasty on those. But what are your thoughts? Do you have guidelines for maybe the older person gets a fusion, the younger person gets a laminoplasty, or what are your thoughts? Because I think it's a little bit of almost a paradox, right?
Yeah, I mean, I think there's no perfect answer for that type of patient. I think either way you're taking a risk. But I think if someone is so decompensated in the sagittal plane from the thoracolumbar deformity, and they're already in a position where they're hyperextending their neck maximally just to look forward, I think if you fuse them in that position, I don't think they're going to be that happy. And plus, if you end up wanting to come back and correct overall thoracolumbar deformity, they're stuck in this hyperextended neck position. And so they can't compensate back once you fix your T1 slope. So I think laminoplasty is probably the better choice for those deformity patients. Plus, they can get back to your deformity surgery a little bit faster with a quicker recovery.
Yeah. Even that example that you showed, their T1 slope improved a little bit after.
It did, yeah.
Right. So it's like, as long as it's like the muscle rehabilitation, allowing them to work on their extension without pinching their spinal cord and having that guarding, it's worth, at least for me, it's worth the gamble. And mainly because there's going to be a subset. It's a continuum, right? Spine care is a continuum. And somewhere along the line, we want to stop or have enough of a pause until people get through their lifespan. So if you have if you have a deformity, then you have to, and it's significant for the patient, then you're actually treating the deformity first. And that should be part of your overall treatment plan, is to tackle that deformity. But if their deformity is not the main problem and their myelopathy is, then operations to basically buy time might make more sense, right? And that's what you were saying.
Right.
You're typically saying you're trying to buy them more time.
Yeah.
Every operation that you do will make the next operation hopefully a little bit easier or safer neurologically for the patient.
Mm-hmm.
Right. So once you open it up, if you have to do an anterior surgery, it's a little bit easier,
Right.
safer.
Yeah.
You're not working in a rock and hard place.
Exactly.
And you have to do a long posterior surgery. You could instrument. You typically, all the subaxial screws are not great anyway. You're going to go to C2 anyway.
Yeah.
So you typically have a pretty good shot at C2 with the laminoplasty.
Yeah.
Right. So that's my thoughts on it. Anybody? Oh.
Thank you for the great talk. I did have a very a question which you kind of addressed, but you were talking about laminoplasty was developed in OPLL, but there is some potential evidence that there is progression of OPLL with laminoplasty. Have you seen any change in the trend of use of laminoplasty, or any cases that you treated where there was progression of OPLL with laminoplasty? I had one patient which I observed it after like 3 to 4 years, and we had to proceed with a revision, decompression, fusion. So what's your experience and thought on that?
To be honest, I don't treat that many patients with laminoplasty just based on the patients that I see. So it is a small percentage. But I would say that in general, if someone is younger and has a very aggressive, looking OPLL, I'll probably lean towards fusing it, kind of like that patient that I showed. But if they're, 70 years old and they have just this slow growing longitudinal OPLL, I'll feel pretty good about opening that up with a laminoplasty. I think it's a little bit of a judgment call. I don't have a great answer to that.
Okay. And we just finished 100 cases of severe OPL, 3 more levels, evasion rate more than 60%. With the RCT trial, RCT study with one of the multi-level laminectomy plus instrumentation. Another one is just a single OPL with the muscle open procedure with the preservation, unilateral muscular preservation procedures. So after 2 years follow-up, then we found that all the neurological recovery rate will be similar. There's no difference, but the OPL progression is different. With a single level, just open laminoplasty, the OPL will grow in 2 years, but not transversely. It's horizontally. It's going up or lower, but AP diameter in that direction, not so much. So in 2 years follow-up, there's no neurological deterioration, sometimes after the decompression operation. So we think maybe for the OPL long segmental fixation, it's not so necessary. In 2 years, we still continue to follow up the patient, but not so less, just like we expected. Because when we designed this study, we expected the long segmental fixation will stop OPL growing, and for the open door laminoplasty, will grow much more faster and bigger, and compression the spinal cord again, but it doesn't happen. So just stop growing longitudinally. Yeah. But not so much serious.